And that way, this program will be up online tomorrow. I'll have it posted on our website, which is www.villagesofsantafe.org. And the great thing there is you can watch this program, you can review it, and then you can also tell your friends to go watch it and get more information. So just a little bit about Villages. Welcome to our wellness series. And our programs are offered on a regular basis with topics related to healthy aging. They include information on Medicare, understanding emergency department, urgent care, fall prevention, our program today on rehab and home health care. And the coming events are listed on our website where you can register. And most of these events are free. Today's topics will relate to recovery and help at home. And you may need help in recovering from surgery, injury, or illness. And the issue is, when you need that immediately, where do you go? You're in a situation where somebody in your family or yourself has been hurt or hospitalized or you're injured, and it's not the time to start trying to find help. So that's why we do these seminars and these workshops, so that you can get information and start making go do your research, find out what's available in your local area. So what we have here today is inpatient therapy, home health care, and outpatient therapy. And the presentation discusses the nuances of rehabilitation and compares the differences between acute, subacute, home-based environments. And we're going to explore the distinctive features of each rehabilitation setting. We're going to discuss the advantages and considerations associated with each, and how you can maximize your time to enhance your recovery. And rehabilitation is a crucial element on your way to recovering from an injury or surgery, or getting you back to or even better than how you were before. And as I said, we do have a recording being made of this at this point. We will have Q&A during the sessions after each speaker. And we will also you can put your questions into our chat. So because each setting depends on the type of therapy the patient needs, we'll also cover the questions you need to ask to ensure you receive the proper care in the right place at the right time to increase your strength, stability, and comfort. If you have questions, please put your questions in the chat. And the Q&A will be open after every presentation. So if you have a question about one part of the program, we can do that right at the end of that part, so you don't forget what you want to ask. Or you can just put it into chat and we will get to that question. The recording will be available tomorrow online at our website. So I want you to meet the experts. So this is fun, because one of the great things that I get to do is meet people in our community that provide services to our older community. So we have Katie Titus. She's the clinical supervisor inpatient rehab therapy at Christus St. Vincent's Regional Medical. So Katie, wave. We also have Bernadette Romero Jaramillo, and she is the clinical manager at Christus St. Vincent's Sports Medicine. Bernadette is you're going to kind of see her, but she's actually having to work from home because she got snowed in this morning as well. And then we have Elise Ponton, who is the chief nursing officer with Nurses with Heart. And good morning, Elise. Good afternoon. We actually are at this point. These experts will cover their specific areas of expertise and answer your questions. Again, we'll have Q&A after each session. Put your questions into the chat. The only thing is we just can't offer specific medical advice. So we will answer questions based on the areas here, but not specifically to your health needs. So first of all, I'd like to then turn this session over to Katie Titus, and she will talk to about inpatient therapy. And so Katie, if you will introduce yourself and we can get going.
Yes. Hi, everybody. Thank you so much for taking time to be here, snow or no snow, wherever you live. I'm Katie Titus. As Anne said, I'm the clinical supervisor for the therapists in our inpatient rehab unit at Christus St. Vincent, and I've been here 11 years. And rehab is all that I've ever done, but I work in a hospital that also does acute care, and we're kind of the middle ground for discharge planning above and below our setting. And so I have a lot of knowledge about inpatient settings for rehab. So again, thank you for joining. Let's start by clearing up a common misconception about the word rehab. People often say that they rehabbed an injury. So many people think that rehab and PT are synonymous, but that's not quite accurate. According to the World Health Organization, rehabilitation is defined as a set of interventions designed to optimize functioning and reduce disability in individuals with health conditions in interaction with their environment. So when you think about rehabilitation, you should really think about a team of diverse professionals working in a variety of settings to help maximize function and minimize disability. Next slide, please. Another potential misconception is that all therapists work in outpatient clinics. That was a misconception that I had until I actually applied for PT school. But the truth is that you might encounter a therapist in the emergency department, or 10 minutes after you wake up from surgery, or the day you come out of sedation in the ICU, or after you've been in the hospital for a week or a month, or in any of the inpatient settings after the hospital that I'm going to discuss, or in your home after you're discharged. And certainly if you're given a prescription for outpatient therapy, that's when you'll see a PT as well. When we think about post-acute care settings, the most common way to differentiate them is by medical acuity. Medical acuity refers to a need for direct medical oversight and intervention, or higher risk of medical emergency equals higher acuity. So here's a list of places you could be discharged from the hospital other than your home in order of highest to lowest medical acuity. You could be discharged to each one of them in order. So you could go acute care, long-term care, acute rehab, etc., or maybe two of them. In rare circumstances, one could transition from a lower acuity level of care to a higher acuity level of care, but that's a little bit more rare. We'll discuss some of the defining features of each of these post-acute facilities, including more in-depth details about what therapy might look like in the setting in which I practice, which is rehab. Next. A lot of these practice settings sound really familiar, so I'm going to try to be really clear about what I'm talking about. The very first step in your rehabilitation journey after an illness, injury, or surgery in which you are hospitalized is acute care. Acute care means hospital, so anywhere in the hospital is acute care. The most important function of an acute care therapist is to evaluate a patient in the hospital and make recommendations about what their follow-up care should look like when they leave the hospital from a rehabilitation perspective. Encounters with therapists in the hospital are usually not scheduled, so they may just show up at some point, usually between 7:30 and 6 or so, and they're usually fairly brief encounters. There's strong interdisciplinary coordination between therapists, nurses, physicians, dietitians, respiratory therapists, and case managers to make sure that the patients that we work with are safe to participate in mobility, self-care, and swallow evaluations and treatments. You might only see a therapist in a hospital one time, or if you're there in the hospital long enough, you may see us as often as once a day, but more often it's going to be 2 to 3 times per week. To make sure that you're progressing to be able to tolerate whatever your next level of care might be, including returning home safely if that's an option for you. The average length of stay in acute care for a patient is 5 to 7 days. So as I said, I'm a physical therapist, by no means an insurance expert. I'm going to give you really sort of vague descriptions of how insurance works at these different levels of care. But the most important person to talk to when you're in the hospital deciding where you're going to go after is your case manager or social worker. So they'll help you verify your insurance benefits, including how long your insurance will continue to cover you during your inpatient stay wherever you are, whether there's a maximum lifetime benefit, whether you will incur any co-insurance charges, etc. So in general, all acute and post-acute settings are covered by Medicare Part A. One little caveat is that if you're having an elective procedure, like a joint replacement, it may be considered an outpatient procedure now. So that would mean it would fall under Medicare Part B. Next. If you're in the ICU or a similarly high intensity care unit in the hospital and you will require ongoing frequent medical care that precludes you from returning home, you might be discharged to what we call an LTAC or long-term acute care facility. One of the biggest differences between LTACs and their other inpatient counterparts, which are skilled nursing and rehab, is that patients in an LTAC cannot usually tolerate the intensity or frequency of therapy provided at the other two facilities. So these tend to be sicker people. Next. As with every post-acute care setting, patients will receive the therapies that are relevant to them, including occupational, physical, or speech therapy, and/or speech therapy. There's no minimum or maximum amount of therapy that a patient in an LTAC must receive. The coordination between the therapist and the other medical professionals remains high in an LTAC, just like in an acute care setting, because of the relatively high medical acuity of the patients who are admitted there. The average length of stay in an LTAC is 25 days. So this slide highlights the details about LTAC coverage for Medicare Part A. The therapy you receive at an LTAC does not have any impact on your coinsurance or deductible, but there are criteria you must meet to qualify for admission to an LTAC. So you must be admitted to an LTAC either directly from the hospital or within 60 days of discharge from the hospital. And you have to have at least one of the following medical necessities. So all of those that are up on the screen: IV issues, so either challenging changes in your IV medications or 24-hour IV fluids, really unstable medical conditions that don't require the same level of specialist oversight that they did in a hospital. So you're not needing to be in the hospital anymore, but still need pretty constant medical care. New or increased dialysis needs with other medical challenges, or wound care needs, specialized wound care needs. So as you can tell, there's no requirement for admission to an LTAC that has anything to do with therapy within these criteria. But because patients stay at an LTAC for a pretty long time and they've often been hospitalized for a long time before they get there, therapists often work with these patients to address declines in their function, independence, or safety. So the next highest level of acuity after an LTAC is acute rehab. So just to recap, we're talking about acute care, which is a hospital, then long-term acute care, and then acute rehab. If you're a little confused already, you're not alone. So acute rehab is also called several other things: inpatient rehab, both inpatient rehab hospitals, like Craig Hospital in Denver is an example of a freestanding rehab hospital, or inpatient rehab units within a hospital like mine. So ours is the Christus St. Vincent inpatient rehab unit within the building of a hospital. And often we just shorten inpatient rehab or acute rehab to rehab. So that's why this is really important that you understand what these different terms mean, because it can be very confusing. So another sort of surprising consideration is that we go from highest acuity to next highest acuity, but we go from least amount of therapy to most amount of therapy between these two levels of care. So inpatient rehab facilities frequently admit patients with acute neurological injuries like spinal cord injuries, brain injuries, or stroke that are known to benefit from early intensive therapies to promote neurological and functional recovery. We also see patients with scheduled or unscheduled surgeries resulting in a new weight bearing or mobility restriction, along with many, many other diagnoses. There's still 24/7 nursing care in rehab and 24/7 on-call physician oversight, plus 5-day per week physician management of a specialty variety called physiatry. That's a rehab physician. As well as internal medicine to help consult on medical needs, including medication management, dialysis, fluids, lots of things. Although all of these conditions tend to be more stable in rehab than they would be at an LTAC. A very general guideline for admission to rehab is that we expect intensive therapies will allow patients to improve their function significantly within 7 to 12 days, ideally to return home or to the community, including to independent or assisted living facilities. So acute rehab units, hospitals, and facilities all have a big focus on utilizing equipment, technology, and their spaces to help simulate real challenges of home and community environments for our patients. Each therapy session is usually 30 to 90 minutes long, and the types of interventions provided vary greatly from patient to patient and by each type of therapist. So the 3 types of therapy I'm talking about are occupational, physical, and speech therapy. So some examples of specific interventions that an occupational therapist might provide in rehab include educating people on how to use different tools to help get themselves dressed if they can only use one arm, or they can no longer bend down to reach their feet, or practicing maneuvering a wheelchair or transporting items within their home, just to name a few. Interventions that a PT like myself might provide in this setting include assisting patients with moving their leg on a treadmill to help them relearn how to walk again after a stroke, or providing exercises or balance training to address limitations due to a number of illnesses, injuries, or just prolonged hospitalization. Interventions that a speech-language pathologist, aka speech therapist, might provide in rehab include using electrical stimulation to strengthen a patient's swallow muscles if they're choking while they're eating, or using technology games or strategies to promote better memory and problem solving. Again, this slide gives some details about Medicare Part A coverage for acute rehab, including deductibles and coinsurance. You'll notice a lot of them are really similar from level to level, and that's why we say that Medicare Part A is sort of the inpatient benefit across the board. Next. So the criteria for admission to rehab include direct admission from a hospital or from home if you were recently discharged, but most often directly from the hospital. Need for rehabilitation physician, which is again called either a physiatrist or a PMR doctor, oversight 5 days per week, as well as specialty physician oversight at least every 2 to 3 days. So this could be a nephrologist, it could be a podiatrist, people who have, they're going to be overseeing some of your other comorbidities while you're in rehab. Regarding therapy, the biggest implication for admission to rehab is tolerance for and need for at least 2 disciplines. So PT, OT, PT speech therapy, OT speech therapy. Usually PT is one of them though. For a total of 3 hours of therapy per day, 5 days per week, or spread over 7 days, 15 hours a week. So that's quite a bit of therapy. This is the highest amount of therapy you will get anywhere. And more isn't always better. It just means that it's a lot. So some patients do really well with this frequency and intensity of therapy, and for some it's too much. So that's sort of the consideration for rehab. If you have Medicare Part A, you do not require pre-authorization for admission to rehab, but you will need approval from the inpatient rehab facility's medical director that you meet these admission criteria. If you have private insurance, you will need pre-authorization from your insurance plus approval from the facility, and your insurance will most likely dictate the length of your stay in rehab. Okay, so last of the inpatient post-acute care discharge options is skilled nursing facility, or SNF. SNF is what we call it in the healthcare world, SNF. So skilled nursing facilities are not the same as a nursing home, although many nursing homes have a designated portion of their facility that are for SNF patients versus long-term residents. There are many patients who could potentially benefit from discharge from a hospital to either rehab or SNF. That's something that we see a lot. So some of the differences or some of the reasons we might consider SNF instead of rehab for a patient is that they have similar medical diagnoses as someone who might require inpatient rehab, but they can't tolerate the 3 hours of therapy a day. Or something about their medical condition will undoubtedly preclude them from discharging home in 20 days or less. Like they're going to be on an IV antibiotic for 2 months that they can't manage on their own at home. Or they have a non-weight bearing injury and they can't put weight on one of their limbs for 6 weeks and they have a split level home and there's no way they're going to be able to manage it. They just need time to heal, but they still need a little bit of therapy. SNF might be a good option. These patients will all benefit from therapy, but whether they receive a lot of intense therapy early on or participate in therapy at a slightly slower pace is not expected to change the trajectory of their recovery. Another example is someone who has really severe cognitive impairments, either new or old, and for whatever reason when they were in the hospital, now they're needing more help and they're not going to be able to return home. Even if they were going to get daily speech therapy, they would still need someone there for safety. So patients who qualify for SNF have similar insurance coverage under Medicare Part A. Admission criteria include at least 2 midnights in a hospital or within 30 days of discharge home from a hospital or a rehab facility. Once in a while, fairly frequently, I'd say 25% of the time, maybe patients come to rehab, they do their intensive therapy and they're still not quite ready to go home. And so they're discharged to a SNF for more lower intensity therapy for a longer period of time before they go home. The average length of stay in a SNF is 20 to 38 days as opposed to 7 to 12 days in rehab, so a little bit longer. Okay, so that was a lot of information to digest. I just want to reiterate one more time, I'm a PT and certainly not a case manager. If you have really specific questions about insurance coverage, either you're speaking with a case manager, social worker, or calling your insurance directly to figure out what your co-insurance deductible look like at these various levels of care would be wise for sure. But I will open it up to questions about these levels of care.
So Katie, when you're, obviously inpatient, the care right there, that's going to be at your hospital. But let's say as you're going down to some of these less intense locations, so those would be separate from the hospital. How are those locations selected, and does the patient have any control over to where they go?
Great question. Yes, patients absolutely have control over where they go. The first question the case manager will usually ask is, do you want to stay in Santa Fe or not? Obviously our resources are a little more limited here. So we have 2 skilled nursing facilities in Santa Fe. There's Santa Fe Care Center and Casa Real. So people who really want to stay in Santa Fe, those are their 2 choices for skilled nursing facility. For LTAC, the 2 that I'm aware of are Kindred and AMG in Albuquerque that are within 100 miles or so. So again, some of it is just sort of what are the choices within a local radius.
And I think in dealing with our questions with insurance, I think one of the best things you can do, if you know, for example, that you're going to be having hospitalization, go ahead and get your insurance card out and call the number on the back of your card and talk to them and tell them what's going to be coming up and get information on their, what's covered, their recommendations. If you're in an HMO or a PPO or a certain at Medicare Advantage, there may be certain places where you're going to be taken that are going to be in that network. So do those things in advance and don't wait till you're pumped up on drugs after your surgery and not really having a good clue as to what they're really telling you.
Yeah, that's a good point, because a lot of people have an idea of where they want to go, and we will always submit for insurance approval before we send someone there. So you may not know until the last minute that, oops, your insurance isn't accepted at that facility, so pick a different one.
Right. Or they just may, you may not realize, but for example, you do have the right to go ahead and say, I want to go there. And then you can have that question as whether you want to pay for it out of pocket, or you realize, oh, well, my insurance is going to cover it over here. So that's going to be, a better situation. The other thing is that we've noticed in a lot of cases is it's hard. I guess you can get transportation to these centers from the hospital, but then coming home, you've got to arrange your own.
Correct. Yeah. Most of the time, if you're going from the hospital to a subacute facility, the subacute facility will provide the transportation. If you're going from subacute or acute rehab home, you're usually looking for your own transportation.
Okay. And I think that really probably, if we have some more questions, please go ahead and unmute yourself and ask the question, or go ahead and put your questions into chat. Be great. What I'm going to do now is go ahead and go on to Elise Ponton, who is Chief Nursing Officer with Nurses with Heart. We've been working with Elise and her group for quite a long time with our fall prevention program. They've given us some great demonstrations of, how to hit the floor gracefully and how to get back up. So Elise is with us today, and I'm going to turn this over to Elise.
Perfect. Thank you so much. So, like Anne said, my name is Elise Ponton, and I'm home health nurse and the Chief Nursing Officer of Nurses with Heart Home Care. So, and I'm going to talk a little bit too about the different types of home care today. So, let's explore how home health care is structured, the duration of physiotherapy in home health care, and the key aspects of rehab in the home care setting. So starting off with home health, unfortunately, one study found that up to 30% of seniors refuse home health care when they're discharged from the hospital. Without these services, older adults' odds of being readmitted to the hospital within 30 to 60 days actually double. So, and our whole goal in home health care is to reduce or prevent rehospitalizations. So why is this happening? Many seniors and caregivers confuse home health care with home care, which is delivered by aides who help people shower or get dressed or cook or clean or serve as a companion. Home care and home health are not the same. Home health care is delivered by medical professionals and home care is not, nor is home care covered by Medicare for the most part. So some people refuse home health because they're confused about what they provide. They're concerned about losing their independence or privacy, while others think they're getting just along fine without any help and have unrealistic expectations of what recovering from a hospitalization will entail. This is why education about why home health can improve care outcomes and a person's quality of life is so important. So thank you all for joining us today. So home health care is designed to provide personalized and convenient healthcare services in the comfort of your home. The focus is on creating an environment that supports your recovery journey, and physiotherapy is a vital component of this holistic approach. So getting therapy in your home allows you to remain safely at home, get therapy where you live versus traveling for outpatient care, especially when that may be challenging. But we need to keep in mind that to receive in-home physical therapy, there are some requirements for home health care. So our admissions process. People may be admitted to home health after discharge from the hospital or after being seen by their primary care provider. We're mostly going to focus on the admission after you've been hospitalized because that's the most common. But keep in mind, too, that you can get home health care, a referral to home health care from your PCP. So to qualify for home health care, the following criteria must be met. So these are the ones on the screen. Be homebound. And what that means is someone who is considered homebound has an inability to leave home and is possibly confined for medical reasons. For such people, leaving home takes a considerable or taxing effort and may require assistance. So some people might be able to leave for short periods of time, but need assistance to do this, and this would qualify you as homebound. You also must need intermittent or part-time skilled services. These include skilled nursing, physical therapy, speech therapy, occupational therapy. These are all skilled services. You must be under the care of a physician. So each referral to home health care must be indicated by your following physician. So it's really important, if no one here has a primary care provider, a PCP that they're seeing, make sure you get set up with one this year because it's really important to have that follow up and follow through. You also must have a home health plan of care, or a POC. We really like our acronyms in healthcare. Once this plan is in place, the following physician will periodically review it to make sure that you're receiving the services that you need through home health care. You also must have a face-to-face encounter. This is required by Medicare. You can't just call your doctor and say, please send a physiotherapist to my home. So you need to have a face-to-face. This documented meeting must relate to the primary reason for home health. Typically, if you're in the hospital, you're going to see a physician. They're going to do an assessment and then refer you to home health care. So that qualifies as your face-to-face encounter. This needs to take place no more than 90 days before or 30 days after the start of home care services, and that is per Medicare. And then you need to have a primary causal diagnosis. Examples of this include joint replacement or surgery, chronic heart failure, stroke. So this is what allows the referral to be approved by Medicare so that you can receive home health care. Primary care providers may write a referral for physiotherapy if, in addition to the previous mentioned criteria, the patient has recent hospitalizations. So this is a referral coming from your PCP. If you're having frequent falls, I would definitely recommend that you talk to your primary care provider about getting set up with in-home physiotherapy. If you require treatment that must be performed by a nurse, like wound care, in-depth wound care. If you are finding that you have a decline in independence with daily activities or with cognition. So some of these things will allow your PCP to write your referral to home health care. Once these criteria have been met, A healthcare professional will conduct an assessment to tailor a care plan to your specific needs. And then physiotherapy in this setting will ensure a smooth transition from hospital to home if you're being discharged from the hospital. And they'll help to facilitate a conducive environment for your rehab at home. So next slide. And so physical therapy in the home. So you've you know a little bit about home health care now. You've been discharged from the hospital. You've gotten the referral from your provider. What does PT look like in the home? So after the patient is admitted to home health care, goals will be set like we talked about before, that plan of care, and staff will be assigned to your case. The focus of all home health specialists is to reduce the likelihood of rehospitalizations, as well as improve your long-term care health outcomes. An in-home physical therapy session will usually begin with a comprehensive assessment and evaluation of the individual's medical history, musculoskeletal function, and level of physical activity. Sessions typically vary in length depending on your needs, with the average session lasting about 30 to 90 minutes in the home. And so PTs will provide assistance with a rehab in a variety of conditions, including post-surgical care. And sometimes this physiotherapy will act as a stepping stone to future outpatient therapy. And that is what Bernadette will catch us up with in the end of this presentation. PTs also, even though they won't do wound care, they won't manage your medications, but they will definitely check on your medication regimen. They'll check out your wounds to see if they have any concerns, and then collaborate with your physician or nurse. That sentence failed to finish. They're also going to look at enhancing your quality of life. So for chronic conditions like COPD or heart failure, therapists may teach patients how to conserve energy while still improving mobility. And then their goal is also ultimately to improve the safety in your home. They may work with the occupational therapist to improve the safety in your home, but they'll also look at evaluating your hearing, vision, and balance so that we reduce the likelihood of falls. And might suggest small changes to your surroundings, like picking up all of those very dangerous rugs that we all love in Santa Fe, but really make us prone for falls. So in-home physical therapy is performed by a licensed physical therapist or a physical therapy assistant. And to practice in the US, physical therapists must earn their Doctor of Physical Therapy degree from an accredited program. And that is who will be seeing you in your home. Next slide. So Medicare coverage. Like Katie, I am not a specialist in Medicare. There are Medicare specialists out there, and there are some that you've seen present for villages. So I definitely would recommend either calling Medicare, the number on your card, like Anne said, or giving some of the other presenters a call about that. So just some basics though about Medicare. Individuals must meet the specific requirements to be eligible for Medicare home health coverage, the set of criteria that we talked about before. And you must be enrolled in Medicare Part A and or Part B. They both provide home health care coverage. But under Part B, a person is eligible for home health care if they're homebound, requires skilled care, and is certified as needing care by a physician. Just the added benefit of Part B is that it doesn't require a qualifying hospital stay. Typically with Part A, if you've been in the hospital for 3 nights, home health care as referred by a physician will be covered by Medicare Part A. But I highly recommend checking into your insurance or with a representative that can confirm that with the plan that you have. This also has a tendency to slightly change every year. So that's why we always recommend checking into with an expert in that. Medicare, what Medicare doesn't pay for is 24-hour-a-day care at home. It doesn't cover meals delivered to your home, homemaker services like shopping, cleaning, or laundry, or personal care like bathing, using the toilet, or getting dressed, except in very short periods. So this is where it gets a little bit confusing. There can be a home care aide that can come in to help with bathing and grooming, but typically it's only covered under home health care. So while you have a home health referral, and it's for an hour, maybe a few times a week. Typically, they're not daily visits. So the other thing too is that we want to make sure that if you get a referral to home health, you must start the home health services within 14 days of being discharged from the hospital or skilled nursing facility. Otherwise, you have to go back and get that referral rewritten by your physician. So it does expire and Medicare will not cover it. Keep in mind that home health agencies are not required to accept patients if they can't meet the patient's medical needs or scheduling needs. So you may have to call around to several different home health agencies to find someone that can service you and your needs. Next slide. So duration of care. The duration of physiotherapy and home health is highly individualized, which is a good thing. The length of treatment varies based on your unique needs and progress. And for the chronically ill and disabled, the goal of home health is to maintain the highest ability of health and wellness. So to make the most of your in-home physiotherapy, you need to actively participate in your sessions, follow your physiotherapist recommendations, and communicate openly about your progress and concerns. To benefit, you got to do the exercises, and it needs to be more than just with the PT. So you got to do them when you're at home by yourself after the PT is left. It's really critical that you do your exercises as often as they are recommended, which means exercising when the PT is not visiting. I literally cannot say that enough because we see a lot of people who just practice when PT is there. And your commitment really significantly influences the success of your rehabilitation. So you may also want to, while you're doing PT, consider complementary lifestyle adjustments, such as maintaining a balanced diet, staying hydrated, and making sure that we're incorporating gentle stretching and additional exercises in our daily routine. These practices help to synergize with physiotherapy to enhance your overall recovery. And so if you're having trouble getting motivated doing your exercises, would always ask someone to do them with you, like a family member or a caregiver, or set achievable goals, like doing sets of exercises during commercial breaks when you're watching TV. So in terms of duration is not only dictated by how well you're progressing, and how well you're progressing is based on how much you're doing on your own, but also ultimately your overall ability. So Medicare will pay your home health agency a set amount of money for 60 days that you need care. These are called episodes of care. And then if your home health agency denies, cuts back, or stops your care, it will be because it believes that Medicare will no longer pay for home health care services that a doctor has ordered for you. And the agency will also give you a home health advanced beneficiary notice to let you know that these services will be discontinued. Typically, home health care lasts for 30, 60, or 90 days. It's uncommon for home health care to be certified beyond 90 days. I have seen it happen. However, like I said, a lot of it is based on your progress. So if they feel like you've met your capacity for what you're going to be able to do, typically they'll discontinue care. If you disagree with this decision, though, you may have the right to a fast appeal through Medicare if you think your services are ending too soon. So what you can do is you can ask your home health agency about how you can contact the local beneficiary and family-centered care quality improvement organization. It's a long one. Its short is BFCC. I had to write this down, BFCC Q10. And what they do is they request a fast appeal to reevaluate your needs for services. Essentially, call the number on the back of your Medicare card, say my home health care is being discontinued and I disagree, I'm looking for an appeal, and then they can start to put that appeal in. Next slide. So talked about PT in the home, how long it's going to last for. Where are we going to get PT from? There's a couple of different agency options that you can go with, and this is where terminology is really, really important. So we're going to take a step back to look at what type of agencies can provide you with PT. So we have 4 different types of care providers. Not all of these are covered by Medicare. Not all of these are licensed by the Department of Health. To start with, we have our private duty and home care agencies. So these are agencies that will assign you caregivers. They may have a business license. Some private duty do not have a business license. They're just private caregivers in the community that are providing caregiving services. They're not covered by insurance. They're not covered by Medicare. And they are not licensed by the Department of Health. Then we have home health care, which requires a license from the Department of Health. So Nurses with Heart, we are a home health care agency because we have a license from the Department of Health, which allows us to provide medical services such as skilled nursing. Not all home health care agencies are certified by Medicare or insurance. Nurses with Heart is not. However, if they're licensed by the Department of Health, you may receive reimbursement from your long-term care insurance for our services. Then our last type of agency is home health care companies that are both licensed by the Department of Health as well as Medicare certified. So companies like these in our area are companies like Amber Care, Presbyterian Medical Services at Home, Gentiva, which is now Good Sam, companies like this. So these are the ones that you're going to call so that you can get your skilled nursing services, your PT, your OT, and your ST. Like I said, there are several different types of payment options. You're going to see private pay options through private duty, home care, and home health care. That's not licensed by Medicare, but then Medicare will be covered by home health care as long as you have a referral from your physician. Next slide. So home health agencies, going back to our agencies that can provide physiotherapy. These are our home health agencies. Again, these have a license from the Department of Health. They're insured by, licensed by Medicare. They take insurance. They're going to be providing skilled nursing, PT, physiotherapy, occupational therapy, OT, ST, which is speech therapy. They can provide wound care, some medication management, some intravenous treatment. They'll do catheter and stoma care. They'll do education. They might have some health consulting, as well as may do a little bit of telehealth. Again, these services are typically covered by Medicare or your insurance when it's referred through a physician for home health. And just to review, home health care is not home care. That's going to be on the next slide. So let's move on to our unskilled care. Perfect, thank you. So home care agencies, which include private duty, home care, and then Nurses with Heart also provides home care agencies. So we have skilled and unskilled care. Typically what unskilled care looks like in the home care field are caregivers or care aides. This is where people are going to be helping you with personal care, bathing and grooming, toileting, meal preparation, light housekeeping, transportation, but also something really important is assisting people with completing their PT exercises. So it's part of this holistic care model. Home care, these services are typically called custodial care, and custodial care is not covered under Medicare. And so people get sometimes very confused about this. So in terms of home care agencies, because some of these agencies may not have a license from the Department of Health, they may only have a business license, or if they're private individuals, they will not have a license at all. We want to make sure that we're asking these agencies if they do background checks on their staff. We want to ask what kind of training is provided to their staff. Unskilled home care agencies are not required to provide any training. They're also not required to complete background checks or do any drug testing. And you're also going to want to see if they have staff that are available to provide you the hours of care that you prefer. And if you have any special needs that need to be met, like language preferences. Next slide. So going back to our agencies that provide physiotherapy, question that we often encounter is, how do I find a home health agency? Well, if you're at the hospital, they're going to give you a list of resources. And so you can call around. This is the list that you're going to see all your home health agencies on that are certified by Medicare. You can also go to medicare.gov, do a search in their search bar for home health compare. It's going to bring up home health agencies in your area that will provide all of their information as well as the services provided by that agency. So if you're having issues running through the list that the hospital gives you, you can also go to medicare.gov for local resources. Also talk to you're going to have a discharge nurse planner. If you're at the hospital, talk to them about their recommendations. Ask your doctor about who they frequently work with. And then also talking to your friends and family. Almost everyone I've talked to has had some sort of experience with home care, with home health care, or with doing inpatient or outpatient rehab. So talk to your loved ones, talk to your friends about their experiences, and they can help you give you some better insights to what's in our community. And do we have any questions about home health care and PT? I know we we went through quite a bit there.
So Elaine, with
yeah.
home health care, so give me the differences. You got home health care, and that is going to be skilled, and home care is not. Is that what it is?
Yeah. Yes. Yeah.
Okay. So home care, home health care is skilled home care. Okay. So home care, let's look at home health care. So before you go in, let's say you're going in for a hip replacement, and you live alone, and how, can you get that list in advance so you can set up transportation just to get home?
Yes. So home health care won't provide transportation to get home. And what I would do, you can ask, so say you're going in for a joint replacement surgery. Typically what they do is you will have some sort of pre-meeting with your surgeon, and some of the hospitals too offer classes of, like, say you're getting a hip replacement, you'll go in for an hour and they'll talk to a group of you about what to expect and when can you shower and when should I change my dressing. They'll also give you a list of resources at that point. So it is, if you can call before and call around to do your interviews beforehand, it's much better than, like you said, Anne, when you're laying in bed and you're hopped up on all your pain medications, you're trying to figure out how you're going to get home and who's going to help you out there. It's better to do it beforehand. You can also do a Google search. So I would do a Google search for home healthcare Santa Fe, New Mexico, or the best thing is to use the medicare.gov page, because not only will that give you local home healthcare resources, it will also give you their ratings if they have them within the Medicare system.
Okay. We had a question why some home health care are licensed but not reimbursed by Medicare.
That's a really good question. So Nurses with Heart, we are not licensed by Medicare. That was a choice that we decided that we weren't going to follow through on. Medicare reimbursements are extremely low and very challenging to process that system, which raises the rates of care. It's also extremely limiting. So some people want skilled nursing beyond 90 days. Typically, if you can't fill your medication boxes after having a home health nurse helping you for 60 to 90 days, you're going to need help beyond that. Medicare doesn't allow those agencies to assist beyond that. So that's where we fill in the gap of, if you need skilled nursing beyond what Medicare will provide you, that's where we come in and we can provide skilled nursing for that, as well as that home care side of caregivers. The other thing too, with Medicare is that it is fairly expensive to get involved in. And so that's why you typically only see very, very large agencies or franchises certified by Medicare.
Okay.
Yeah,
thank you so much. Thanks. Now we're going to introduce Bernadette Romero Jarillo. She is the clinical manager for St. Vincent Sports Medicine and Therapy Services. So she is going to be participating. I'm going to ask her to unmute right there. And there she comes. But she got snowed out, so she's working from home. So I will mute myself, and Bernadette will introduce herself, and we will proceed from there.
All right, you can hear me, Ann?
Yeah, you're great. I can hear you.
Okay, great. So, yes, my name is Bernadette Romero Jaramillo. I've been a physical therapist. I'm going on 23 years. I've actually practiced in all areas that we've discussed in this presentation. I started as an inpatient rehab clinician, moved into home health care, and then now I've been in the outpatient service settings. So we'll start with outpatient therapy services. They may offer physical, occupational, and speech therapy. So outpatient is defined as the patients coming to the clinic. At the clinic where I am currently working, Christa St. Vincent Sports Medicine and Therapy Service, we do offer all three disciplines at the clinic that I'm at. So we do offer physical, occupational, and speech therapy. We do have some cases where patients do come in from other hospitals or from our hospital and need that continuation of the three therapies, and then they will continue on with their outpatient services from there. Also, there's quite a few private clinics in Santa Fe, and these clinics may only offer one or two options of the therapy. Typically, that's more physical and speech, or excuse me, physical and occupational therapy if the two are within the same clinic, or majority are physical therapy clinics. So next slide. So in the outpatient therapy services, there's multiple diagnoses and conditions that range from acute type of injuries, which is considered new, or chronic, which have been long-term. And in these outpatient clinics, we may provide treatment for the following conditions, such as hand therapy. So there's physical and occupational therapists that specialize in hand therapy. Also, lymphedema therapy, which is for specialized clinicians, both physical and occupational therapists. And it's a specialized type of massage for lymphatic drainage. And they also do specialized wrapping. And they also treat not just lymphedema, but a type of diagnosis called lipedema. And then we have orthopedic cases where the clinic should be able to treat all joints that are involved with either after a type of surgery, or it could be arthritis or just an injury of some sort, which would fall under a non-surgical injury. Also, the clinic would have access to neurological conditions, so post-stroke or patients with MS or spinal cord injury, just in the whole gamut of anything that is based under neurological. Also pelvic health, and that's actually my area. I've actually specialized in pelvic health in the clinic that I'm affiliated with, and I work with both women and men on a variety of different cases of diagnoses. We also offer vestibular rehab type for balance, which could be associated with inner ear issues. It could be neck issues that may be causing dizziness, and just working on balance and stability. And then there's also clinics that may offer wheelchair evaluations for those patients who are wheelchair bound, to be able to be assessed for the proper dimensions or seating for what's needed for proper wheelchair mobility and seating. And then, of course, speech therapy, which carries over from our other presenters in terms of our speech therapy do the swallow, the cognition, and they also provide electrical stimulation treatments for the muscles around the face, neck, and mouth. So next slide. All right. So when do you start outpatient therapy? Well, typically, outpatient physical therapy is usually after being discharged from the hospital, or perhaps you've been discharged from home health therapy, or you had an outpatient procedure type of surgery, and your physician may recommend that you start outpatient therapy. And then another big part is patients just advocating for themselves when they go to see their provider and will say, I need to see physical or occupational or speech therapy. And so they'll get an order in that sense. But in the state of New Mexico for physical therapists, because we are a direct access profession, you do not need a referral. However, this does differ for occupational and speech therapy. But going into the next slide is majority of insurances will require a referral for outpatient therapy to be covered. So you will need a referral for that reason. So typically you'll receive that referral from your PCP doctor, which could be your MD, your doctor of osteopath, your nurse practitioner, chiropractor, doctor of oriental medicine, or a podiatrist can refer you to outpatient therapy. The patient will communicate to the clinic and provide insurance information so that clinic can verify insurance benefits prior to starting your physical, occupational, or speech therapy. We want to make sure that authorization is done before starting on your initial evaluation, because we want to make sure that your insurance benefits have been checked to ensure that the patient is aware of what the cost is out of pocket on their side. Or if it's a Medicare beneficiary, which is going to be the next slide, patients utilize their Part B Medicare insurance. However, in the outpatient setting, we do have a threshold for physical and speech therapy combined of approximately $2,300. And then there's a separate threshold for occupational therapy for $2,300. So this can average out to approximately 20 visits per calendar year. Now, majority of our Medicare beneficiaries usually have a secondary insurance. So that would cover the 20% of whatever Medicare does not cover. So usually those patients are covered 100%. Or if a patient just has the Part B Medicare insurance and does not have in secondary, they would be responsible for that 20%, but it is based on the Medicare contracted rate. And so that is what the percentage of what the patient would owe is based on that dollar amount, because everybody has different dollar amounts. As far as like an example, the outpatient clinic at the hospital that I'm at, we have a higher a dollar amount, but then we have to go by the contracted rate from the Medicare contract. So next slide is then talking about when you start your physical therapy, you're going to come in and have what we call an initial evaluation, which is going to provide, the therapist is going to provide you with a plan of care, and they're going to perform this evaluation to determine what the plan of care of treatment plan and the number of visits that are going to be needed for you to achieve the goals. And that conversation takes place between the clinician and the patient on the first day. So we set up a time or duration of, I think we could achieve this in 6 weeks, or perhaps if it's a post-surgical or it's a very acute neurological type of condition, we're going to need a longer duration of weeks to try to achieve those goals. So through that evaluation, your therapist will take objective measurements, and they'll take these objective measurements based on motion, as far as how your joints move, flexibility, your strength, and also evaluate you in terms of using a functional tool that we assess, and based it on, it depends if it's on balance or if it's on activities of daily living. Can you reach? Are you in a lot of pain? And then it's all documented and sent to your referral source and the insurance company to explain to them the why the patient needs the skilled physical therapy. So the next slide is follow-up treatment visits, which the patient will receive an individualized treatment from their therapist. Their therapist will design and administer this personalized rehabilitation program to help the patient achieve their goals. And again, these goals are based on improving everyday function to help the patient's quality of life. And we base it on what our findings are objectively. It could be pain or strength or whatever else that we find. We're going to focus on those types of treatments, which is the next slide. So the therapist professional has multiple treatment approaches to help manage and control the patient's pain, improve the range of motion, flexibility, strength, quality of body movement. And these could be managed by manual therapy, which is included with what we call soft tissue mobilization, where we're working on fascia release, or massage, where we're working a little bit deeper into the muscles. Joint mobilization, you're having difficulty with moving your knee or your shoulder. We have special techniques on trying to get the joint to open up and move. Lymphatic drainage, again, for a lot of patients with a lot of edema or swelling, we try to get that out of your system so your body starts to heal. We work on therapeutic exercises, which can include flexibility, strengthening, focusing on core, your trunk, your posture, and so forth. And then home exercise instruction is very important, just as it is in all aspects of the models that we've been speaking about, because we do want our patients to be independent with their home exercises, because it's a lifelong continuation of making yourself feel better. I tell my patients that it's really I feel like a physical therapist, as far as as a physical therapist, I'm 10% of the puzzle, where my patient is the other 90%. And I'm going to help give them the tools to help them achieve whatever it is that they need. But the patient needs to continue to work on their exercises that we're instructing them on to maintain pain and strength and daily functional tasks. We also focus on safety strategies by going over proper assisted devices. Do we need to tweak your walker? Do we need to progress you from a walker to a cane? Do we get rid of the cane? Do we evaluate in ways to help your home and your environment a more safe environment? Also, patients with surgery, we really want to focus on joint protection in the first phase of healing, and then progressing patients as they continue through their next phase of rehab. So continuation of types of treatments would be also what we call biomechanic training, which is restoring proper posture alignment. It's so important, as we've been talking about fall risks. Our tendency as we age is we want to get our posture in a more forward position, because we do everything in front of us. So us, as being the biomechanic experts, we want to teach our patients the importance of proper posture and proper gait training to help you walk better and improve your balance and work on your sitting strategies and your standing strategies to help you gain both what we call static, is when we're working on balance in a still position, and dynamic is when we're moving in balance in a more bigger and movement position. And then we also offer other treatments in the outpatient setting that we would provide electrical stimulation, and we use it for a variety of things, such as pain management, or also re-educating a nerve that has been injured, or trying to get the brain to communicate with the system on trying to properly use the muscles the way they were prior to injury. We also have ultrasound, which is utilized for pain management and healing, tissue healing. Hot and cold pack could be for, again, pain management or for swelling control. We have systems or traction systems within our clinic that actually traction or separate the spine to try to help with providing pain management. For instance, a patient with a disc herniation, we have a traction system that can help place less stress on that disc to allow that disc to try to go back into alignment. We also, as physical therapists and occupational therapists, offer treatments such as dry needling, which is for pain management. And then we also have what's called BFR, which is called blood flow restrictive therapy. So it's like a blood pressure cuff that goes around your extremity, and you're working to your most powerful ability while the blood flow is not going to the muscle, to try to work on trying to get higher strength, because there's a lot of evidence that shows that you'll get stronger with this particular treatment. And then we use taping, such as we have McConnell taping or leucotaping. We're trying to line the bones or the joints in a certain way so we can retrain the muscles to work correctly. And the same thing is kinesiotaping. So we utilize that for swelling or edema management, for pain management, and for also alignment of the joints to help us retrain the muscles correctly after insult and injury. So next slide. We're going to go into, so as we discussed, there's a duration of time line that we have to set on that initial evaluation. And then at that midpoint, we're talking about doing a re-evaluation, because we're starting to talk about discharging. We always want to have a plan for discharging. So your therapist will perform a re-evaluation to determine if the goals that were set on that initial evaluation are being met in the time frame that was documented. We would retake those objective measurements by showing, are you improving, or are you staying the same, or have you gotten worse, to determine if it's helping or not. And then if we see that it is helping and you still need a few more visits, then we would then document that and indicate that in our notes, and we would update our plan of care and send it off to the referral source and to the insurance company to give for more approval of your need for your skilled therapy. So the next slide is, just still honing in is, making sure that reevaluation and the goals are being met in the time frame that was documented, or have you met your goals? And if you've met your goals, then you're ready for discharge and getting into that independent home exercise program to continue on with this great lifestyle of tools that you've learned from your therapist, and you continue with that. And then, patients do come back to us. You try it on your own, and sometimes you may need to come back for a tune-up or a realignment of some sort. and it could be 3, 6 months down the road, or it could be that, you're doing fantastic and you don't need to continue with therapy. But our ultimate goal is to give you those tools so you have that continuation of lifestyle improvements. Any questions?
So, with the limitation of 20, let's say average of 20 sessions being paid for, it would seem like that there are situations, obviously, that require, a year of physical therapy. What happens with that?
No, that's a great question. So, it is a threshold. And so what we have to use is these special codes that we have to put into our documentation and into our charging capture that we have to send off to Medicare to say, okay, patient has met their threshold, but we see the potential with the objective measurements that we've taken that they're going to need a little bit more therapy and to continue on with that, with the therapy needs. But it may not be an entire year because we actually help manage those visits for them too. We may say, maybe you can't come twice a week or 3 times a week. Let's see if you drop it down to 1 time a week or come every other week, because there's a lot of tailoring or customization of the frequency and duration that you can do in an outpatient setting in comparison to what we were discussing earlier with hospitalization or home health care.
Do you see much in reading about this? Of course, I started going down the rabbit hole and there's so much information, but I was reading in so many different articles that saying that PT really is a really viable, in a lot of cases, alternative to surgery. Rotator cuffs, things like that. And I had that situation where I ended up with PT where everybody suggested no surgery. So are you seeing more of that these days, and how does that, how is that coming into play with patients and doctors?
No, absolutely. So we see it from all aspects. So patients that advocate for themselves will communicate to their provider, and we do have a lot of providers out in our community that will say, let's try physical therapy first or occupational therapy first to see if it makes a difference in your symptoms before we send you to the next phase, which would be going to see a specialist, like an orthopedic specialist, like the example you gave with the shoulder or the hip. So we're, so it does work on both sides. It's either you're going to have the surgery and you're going to have to come for the therapy, or there's a lot of cases where we still have patients that come before they make that decision to see if they're going to get better or not. And then there's another phase prior to surgery is if the case is surgery, where we'll do a little bit of pre-rehab. We'll have them come in and teach them the important tools and exercises to try to get stronger before they go into surgery, so that muscle memory and recovery will be a little bit faster when they have their procedure.
Yeah, it seems like our main thing, and we, especially with these seminars, we're trying to give people the information so they can make these informed decisions, in advance. But, sometimes it's a bit of a daunting thing. But let's say you've had surgery. Who helps you? I know, is there a patient navigator or a planner that helps you? And at what point do they kick in, and what point do they go away?
That's a great question. So when a patient, and I can speak on the way our system works at Christus St. Vincent's. So we do have nurse navigators or patient navigators that are very involved with our orthopedic physicians, and they follow the patient from as soon as they walk into the orthopedic doctor's appointment, and that appointment decision is you will need surgery. They follow them from that visit all the way through the continuation up, I'm going to say 6 months to possibly a year, just depending on how the patient progresses, because they're constantly checking on them, especially in the beginning phase of post-surgery. So they're helping with navigating on giving them the resources of, hey, there's a couple of places in Santa Fe that they have a closet. It's a loaner closet to loan you equipment if you need a walker, to borrow a walker or a commode for your toilet or a shower chair. There's the agencies for home health care. Here's a list. Here's a list of private caregivers that you may look at for if you live alone. So they are involved as soon as that decision is made, what the patient is going to have surgery. And I want to say maybe they're up to that 6 month check. And then, at that time, patients should be in outpatient setting, that they're becoming more and more independent.
So Katie, for you, it's maybe a continuation of that question. So there's been a surgery or an illness or whatever, and now they're in hospital rehab. But then is the patient navigator, the nurse navigator helping them at that point? And then when they go home, and this kind of involves Elise as well, who's overseeing these different people coming in for therapies, for this patient? It's one of those things. It's almost things like we need this guardian angel sitting over here that oversees everything, and I don't know who that is.
Well, everywhere that you're going to be in an acute or subacute facility, there will be a case manager specific to your setting. So case managers are often nurses or social workers. So in the acute care setting, when you're in a hospital, if you just had surgery or you've been hospitalized for any reason, you're going to meet with a case manager fairly early on, maybe like even days or weeks before you're ready to go home, to start talking about what your options are for discharge. And again, the therapists who are seeing you, if therapy is going to be required after your hospitalization, will also weigh in and work with the patient on what the options are and why we think one option may be better than another. So the patient will be meeting with a case manager or social worker at each different level of care, in the hospital, at an LTAC, at a rehab facility, who will help facilitate the transition to the next level of care. When it comes to home health, I assume Elise can speak to that in terms of what that looks like, overseeing those services. Do you have any other questions about the acute or subacute level, Sam?
I think that's, I'm sure I do. I just don't know what they are.
Okay, thank you.
Yeah, and this is Bernadette.
Go ahead, Bernadette.
What I was going to mention is, so there's different phases of navigators, and again, I can speak from my experience from Christus, is as what Katie was just mentioning in the hospitalization side of things, but there is an outpatient navigator that follows. So like if it's elective surgery and I go into the doctor and I'm going to say they're going to say you need a total knee replacement, there's an outpatient navigator that follows that patient from start to make sure they're meeting and getting all the help that they need and the resources they need to get them to the next phase of, actually, you got to go home with help, or you need home health care, or you need to possibly go into a skilled nursing facility. So there is a person in an outpatient setting that does similar steps that was mentioned by Katie.
Okay.
And then just once you're in the community, and once that navigator has finished their path, and once that home health Medicare referral has run out, there are case management services in the community. So there are some organizations in Santa Fe that just do case management. We also provide case management. And so what that looks like is like a personal assistant for your healthcare. So we're the ones who are calling to schedule those follow-up visits, making sure that you're connecting if you need to get in to see your doctor, if you're confused about why PT is stopped or things like that. The nurse case manager will follow through with those things for you. It's important to keep in mind that case management in the community is always out of pocket. It is not covered by Medicare or insurance.
Okay, thank you so much. So I would love to, if you would, let's see if I know how to do this. Where are my polls? There we go. I am going to launch a little 5-question poll. If y'all will take a couple of minutes to just answer the questions, that'd be great. We only have 6 questions, and then you can fill in your comments. We would love to see your comments and hear your comments. Again, coming up in, I'm going to go to the next slide here, if I can with this. Hold on. There we go. Again, we've got coming up in February, Elise will do a session on vaccinations. We all have questions about the RSV, COVID vaccinations, but we also want to remind people of our life-saving threat vaccinations that we sometimes don't think about, such as whooping cough and other ones, particularly when we're around our grandkids, and how important these are. So that'll just be a 1 hour on February 9th at 1 p.m. on Zoom. Maria and I will be hosting Fall Prevention at 9:30 on February 13th. We really love teaching this class. We've been doing it for quite a while. We hope to get back to some in-person classes in this coming year. So we appreciate your attending all of these. And, don't forget, we have our free classes. If you're not taking our exercise classes, please sign up. Health is wealth. And it really is a situation, no matter how much money you have, if you don't have good health, you're really not enjoying your life and not aging well. So please be sure to exercise. Exercise is the only way we can tell to actually prevent falls. So thank you to Bernadette and Katie and Elise. We really appreciate your time and effort, and it's been a great afternoon. And stay warm and safe, because it's going to get really cold tonight.
Yeah, our pleasure. Thank you.
Thanks for having us.
Thank you.
Thank you.